I bring greetings from India, and I also bring greetings from a country which is, full of patients suffering not only from diabetes but their complications. So today, my interest of submission is, where does the combination therapy of a new class of agent PPAR, gamma, and alpha agonists, Saroglitazar, combined with Rosuvastatin, stand as compared to higher dose of Rosuvastatin monotherapy in patients with type 2 diabetes and dyslipidemia? Here are my credentials. And just let me tell you a small background of the trial. We all know in India that coronary heart disease has has been increasing in numbers, and deaths have been increasing tremendously to the tune of twice every 20 years. And having said that, there have been n number of studies, and these studies have found that almost 90% of the cause of diabetes and coronary heart disease is caused by only three parameters, that is insulin resistance, diabetes, and its associated dyslipidemia. So these are the major modifiable risk factors which lead to acute myocardial infarction and then to death. So this is the Interheart study which focused on the 9 modifiable factors and assessed that these account for 90% of the first myocardial infarction risk worldwide. We all know that diabetes is not a one-day cricket match. So diabetes, what we see clinically in our clinical practice, is just a tip of an iceberg. It starts well on a fertile background of diabetes genetic makeup of that individual, wherein the sugars are absolutely normal, and if you start an oral glucose tolerance, if you do an oral glucose tolerance test, it would be absolutely normal. But that individual would have an altered waist to hip ratio, maybe obese, may have some kind of lipogenesis undergoing in his body, and this is on the firm background of insulin resistance and hyperinsulinemia. Insulin resistance and hyperinsulinemia is also going to cause a disruption in the lipid metabolism, which can cause an increased triglyceride levels, a fall in the high density lipoprotein, and concomitant arterial hypertension going hand in hand. As time passes, this patient will enter the stage of an impaired glucose tolerance, where you would start seeing slight surge in the postprandial glucose, increased hepatic gluconeogenesis, decrease in the glucose transport, and in beta cell starts failing off, and then there is an insulin secretory deficiency. At this very point, you would start seeing
بس دي
clinical
كنقرا
diabetes.
حتى نساليو نهبط
Along with that, you would also see features of
ما كنقرا
micro and macro
ما
angiopathy,
نخليش نهبط
which is the most, dreaded complication, because it is the sheet anchor of all complications of type 2 diabetes. So the story of type 2 diabetes starts not in the clinical presentation, but well 10 or 20 years beforehand. So we must address these atherogenic diabetic dyslipidemia well in advance. So what constitutes an atherogenic dyslipidemia? Atherogenic diabetic dyslipidemia constitutes a high level of triglycerides, a low level of high density lipoprotein cholesterols, and interestingly, the LDL cholesterol, the low density lipoprotein cholesterol, is not significantly increased, but the small dense LDL cholesterol particles are increased. So you would be seeing a dense LDLs increased TG and HDLC. So this combination of a high TG, low HDLC, and an increase in small dense LDL constitutes the ADD, or the atherogenic diabetic dyslipidemia. So why diabetics are more prone to this ADD, atherogenic diabetic dyslipidemia? We all know this, biochemical pathway wherein insulin resistance leads to increase in deposition of triglyceride and increase in lipoprotein B and increase VLDL at the liver and fat cells, forcing the free fatty acids into the liver and not being utilized because of either an insulin deficiency or insulin resistant state. All of them lead to increased LDL, a fall in HDL because HDL goes back through the cholesterol ester triphosphate pathways, and ultimately you would have an increase in small dense lipoproteins. Now, there have been many studies, and of one of the very important studies as far as dyslipidemia in general adult patient population of India was concerned is the ICMR INDIAB study in 2014. And in ICMR is Indian Council of Medical Research, and they did a survey across the country, and what they found was the number one dyslipidemia which was present in the Indian population was a low HDL, followed by a hypertriglyceridemia, which is high triglyceride levels, and high LDL was found to be at the number three. So here also we can see that low HDL and high TG are number one and number two dyslipidemia present in the Indian population. So what we should target, if we need to target, we need to target a high TG, and will, as the talk goes, as we'll explain how and when triglyceride needs to be addressed. So are Asian Indians different? So Asian Indians are tremendously different because diabetic or atherogenic dyslipidemia is characteristically seen in Indians. Indians have a lower high density cholesterols compared with other South Asians. Insulin resistance in the Indian population is associated with low triglyceride and raised triglyceride and low HDL cholesterol. And there have been multiple of studies, the hard score and India score studies, which have shown that 9% of Indians had an HDL cholesterol of more than 50 milligram, while 70% of blacks had and whites had an HDL-C more than 50 milligram per deciliter, establishing that Indians are poor in high density lipoprotein cholesterols. High serum triglycerides were seen in the Indian population as compared to whites and blacks. Now, if we compare it with the American whites, here on the right hand corner of the slide, you'll see that triglyceride levels and lipoprotein levels are higher and HDL is lower, while the other parameters are almost as similar to the American whites. So Indians have a uniqueness in having high triglycerides, low HDL-C. So if we see Indian patients, we can see that of all the male and female counterparts which have been studied of late, almost 90% and more of the diabetic patients in India are dyslipidemic, 85.5% males and 97.8% females. So this is the state of affair in Indian diabetics. So diabetic dyslipidemia is a major concern, and it is this high triglyceride cardiovascular risk. We all know that LDL cholesterol is atherogenic cholesterol, and it leads to myocardial infarction. So do we need to address triglyceride? So do we have any evidences here? Well, there was a study which was published in the New England Journal of Medicine, and which included 75,000 participants, and it was followed for almost 34 years. So you can just imagine, and this was published in June 18th, 2014 edition of NEJM. Here it showed that participants who had a non-fasting triglyceride of less than 90 milligram per deciliter had a 60% lesser risk of cardiovascular events compared to participants with non-fasting TG of more than 350 milligram per deciliter. So triglyceride, high triglyceride definitely meant more cardiovascular events. This was a huge study spread over almost 34 years. Now, after the introduction, what we have been, doing it, and what international literatures have shown us that we need to introduce statins and focus on the LDL cholesterol, and then once the LDL cholesterol is reduced, you start focusing on the high, increasing the HDL-C. But where does the triglyceride go? So here this study showed the hazard ratio of non-fasting triglycerides in myocardial infarction patients and ischemic coronary heart disease patients. You can very well see in this on the left hand side, as the non-fasting TG increased, the hazard ratio of having a myocardial infarction started to increase by almost 5.5. And coronary heart disease, the ISD events, the unstable angina and the stable angina, the hazard ratio increased to 3.2. So we have scientific literatures which have shown by which have shown in confirmation that non-fasting TG levels may be important. Fasting triglyceride predicts recurrent ischemic events in patients with acute coronary syndrome treated with statins. So there are two studies which I like to highlight. The DAL outcome study, which was a randomized double-blind study which included 15,000 plus acute coronary syndrome patients, and they were followed for 31 months. 97% of these individuals were put on statin, as is the dictum, and at a random assignment with a median of LDL-C cholesterol of 73. And the Miracle trial, which was again a randomized double-blind comparison of atorvastatin 80 milligram with placebo in a total of 3,000 plus patients with acute coronary syndrome. The treatment started early, within 24 to 96 hours after admission to hospital for acute coronary syndrome, and continued for 16 weeks. So this was compared with the quintiles of triglyceride, and the univariate relationship was calculated. So the quintiles were TG less than 80, 80 to 103, 103 to 130, 130 to 175, and more than 175. So here you can see that as the quintiles of triglycerides increased, the risk of primary endpoint events, that is another event of myocardial infarction, started to increase. So this was again replicated in the risk of adjusted relationships. Fasting and triglyceride and cardiovascular risks were independent of LDL-C cholesterol, and this was replicated by this DAL outcome. Even when the LDL-C was either less than 73 or more than 73, but as the triglyceride levels started to increase, the risk of primary endpoint events increased. So, irrespective of the level of LDL cholesterol, triglyceride, as it increases, can lead to risk of recurrent myocardial events. Now, we have evidence this. Now, will treating high triglyceride reduce cardiovascular events? So, uh, this was this was a meta-analysis of the famous 4 or 5 trials, landmark trials, where Accord, Field, BIP trial, and HHS and VA HIT trials were assessed, and they were grouped into two arms: the triglyceride more than 204 and HDL less than 34, versus triglyceride less than 204 and HDL more than 34. So triglyceride in the arms which had a TG of more than 204, the odds ratio were in favor of deleterious events as compared to TG of less than 204. So treating triglycerides would mean cardiovascular safety. In different studies in the last 30 years, PPAR alpha agonist therapy with or without statin has been proven to cause significant risk reduction in patients with high TG and low HDL, which is the atherogenic dyslipidemia. So we have evidences, multiple number of evidences where TG has been found to be a treatment beneficial arm. So how do we treat? So we have the established drug called fibrates, which have been advocated for the use of treating the triglycerides. But fibrates do reduce triglycerides, LDL, and raise the HDL used alone or in conjunction with statins. But fibrates increase the risk of gallstone. But when statins are combined with fibrates, the biggest issue is there is an increased incidence of statin-induced myopathy by almost 5.5 folds as compared to statin-used alone. So, and then the issue of hepatotoxicity and increased AST and ALT level is always there with fenofibrates. So we need to have alternative options. As far as statins are concerned, we have known that they are the established and the most commonly used drugs for diabetic dyslipidemia. Statins mainly reduce LDL cholesterol, but they can reduce all the parameters, but they do not have any effect on the HDL levels. They have the strongest evidence for cardiovascular protection. The current American Diabetes Association guidelines recommend statin therapy for all diabetic patients of more than 40 years with anyone or any cardiovascular risk like factor like hypertension, retinopathy, proteinuria, even if LDL is under control. All patients with diabetes and coronary artery disease should be put on statin irrespective of LDL age and to reduce the LDL 30 to 40% from the baseline. But then meta-analysis have shown that high dose of statins can increase the new onset of diabetes risk by 12%. So we need to weigh the balance between high dose statin versus low dose statin. If we could have a drug which would just reduce the dose of statin, so we could have the advantage of statin, the pleiotropic advantage of statins along with the cholesterol lowering effect without increasing the risk of getting the patient diabetic or lessening the control of the diabetes. Now, if we consider treatment of dyslipidemia alone and the advantage getting out of dyslipidemia and diabetes, we have seen that even after optimized treatment with statins, though the risk is definitely reduced, in the HPS it was reduced by 22%, but there is some amount of residual cardiovascular risk remaining even after the optimized dose. Now, this is what is called the residual cardiovascular disease risk. So this residual risk remains even with highest dose of statins. So statins alone are not sufficient in diabetic dyslipidemia. In the CARDS trial, 68% of cardiovascular risk remained even though the atorvastatin arm showed a 32% risk reduction. So statin is not the foolproof answer of reducing diabetic dyslipidemia induced coronary events. So we need to have some other agents which could handle this residual risk. So residual cardiovascular risks have been found in almost all trials, the lipid trial, the CARE trial, the HPS and the CARDS trial. And what is the guidelines, the NCEP and the ADA guidelines on triglyceride and non-HDL goal? Now, if the triglyceride is less than 200, the primary goal should be LDL cholesterol with lifestyle modification and statins as the first choice among drugs. Non-HDL cholesterol should be the second therapeutic target according to the ATP3 in individuals who have a TG of more than 200 milligram per deciliter. So what would favor is fixing the non-HDLC as treatment goal because it is a conceptually uh, better option because it takes care of all the pro-atherolipoproteins. It is a stronger cardiovascular disease factor. All all lipoproteins except HDL. So it includes LDL, VLDL, small dense LDL, everything. It is a stronger cardiovascular risk factor. It is valid in patients with high TG and valid in non-fasting conditions also. So fasting is not required if you want to assess the non-HDL cholesterol. Therefore, it becomes an attractive option because it is also going to address the residual cardiovascular risk remaining even after statin therapy. With the realization of the importance of triglyceride, the suggested target for triglyceride has been continuously going down. So in 1984, where the TG target was set at less than 250, in 2001 it went down to 150, and the global guidelines as of now still says that a TG should be less than 150. So it started from 250, now it has gone to less than 150. And what I propose is that we have evidences which show that at at TG of less than 100 milligram per deciliter, the small dense lipoprotein contribution goes down. So 85% of LDL will be small dense lipoprotein when the TG levels are more than 250 milligram per deciliter. But when this TG is brought down to less than 100 milligram per deciliter, the small dense lipoprotein contributes only to 15% of LDL, which is non-atherogenic. So majority of the LDL cholesterol will now be the buoyant LDLs, which are less dangerous. So if we have this concept of bringing down the TG to less than 100 milligram per deciliter, probably we would be saving more lives. Probably we would be addressing more residual cardiovascular risk factors. Now, TG not only is directly related to the hazard ratio for coronary heart disease, but also there has been direct association of hypertriglyceridemia with insulin resistance. So higher the TG values, more the insulin resistance, poorer the sugar control. So ADA 2013 guidelines said that fasting lipid profile should be evaluated in all patients with diabetes. ATP3 guidelines have changed that total cholesterol, LDL-C cholesterol, HDL-C and TG should generally be evaluated. If the TG values are more than 200 milligram per deciliter, non-HDL-C cholesterol should also be evaluated. Near normal LDL-C cholesterol needs further evaluation for non-HDL-C as it is the secondary target for therapy. ESC 2011 again addressed this issue, and they said that non-HDL-C cholesterol should be evaluated in patients with suspected combined hyperlipidemia, dyslipidemia in diabetics or metabolic syndrome patients. Non-HDL-C cholesterol can be assessed as it keeps in the risk evaluation and is considered as an alternative risk marker. This was the ESC 2011. So, in real life also, evaluation of non-HDL is necessary for early identification of dyslipidemia, especially in diabetics who have normal LDL. Non-LDL-C is a better indicator of residual risk than LDL-C, what I have been advocating for the last 10-15 minutes. So when triglycerides are between 200 to 500 milligram, a non-HDL-C calculation provides better risk assessment than LDL-C cholesterol alone, which was the ACE 2012 dyslipidemia guidelines. Among statin treated patients, the strength of this association with CVD is greater for non-HDLC than for LDLC and apolipoprotein B, which was published in JAMA. An increased level of non-HDLC by 1 milligram per deciliter increases the death due to cardiovascular disease by 5%. So now I have advocated that triglyceride is an important assessment issue in lipid parameters because triglyceride contributes to non-HDLC. Non-HDLC is a residual risk, cardiovascular risk assessment factor. If we treat the non-HDLC, we would be reducing the cardiovascular disease risk factor more. So how to address that? Is statin therapy alone enough? Despite statin therapy, a significant residual risk remains potentially attributable to increased TG and low HDL, which is a characteristic hallmark of atherogenic diabetic dyslipidemia. A meta-analysis of 14 trials involving statins that include 18,000 plus patients with diabetes proved that presence of low HDL and high TG limits the efficacy of statin therapy alone in reducing the vascular events despite achieving the target LDL-C levels. So despite you achieving the LDL-C cholesterol, there is some amount of cardiovascular risk factor, and this is because the low HDL and high TG limits have not been addressed. Now in India, there has been a drug which is called glitazars, which is a combined PPAR alpha and gamma agonist. So let me just tell you a brief outline of what this PPAR gamma alpha are there. PPAR gamma alpha is present in the white adipose tissue, and they have been attributed for adipogenesis, regulating the adipokines productions, lipid repartitioning to fat, and increasing the insulin sensitivity. Brown adipose tissues have the they are converted from PPAR gamma, they are converted to brown adipose tissue, which is dangerous one. PPAR alpha is present in the liver, and they are responsible for fatty acid oxidation, ketogenesis, lower plasma triglycerides, and increased plasma HDL. PPAR delta is present in the muscles, which are responsible for fatty acid oxidation, oxidative muscle fibers, obesity, and insulin resistance. Obesity resistance, improving insulin sensitivity, and exercise physiology. So we are interested in the PPAR alpha and PPAR gamma in the white adipose tissue and the liver. And Saroglitazar acts on the PPAR alpha in the liver and increases the fatty acid uptake, increases fatty acid oxidation, increases the apolipoprotein A1 and thereby HDL, decreases VLDL and triglycerides, decreases the ApoC3, and has some amount of anti-inflammatory effect. PPAR gamma acts is present on the adipocytes of the muscles, and they are related to insulin sensitivity. They improve insulin sensitivity. So there is increase in insulin sensitivity, there is improvement in the beta cell function, there is increase in the fatty acid uptake, there is increase in the adiponectin secretion, and these also have some anti-inflammatory effect. So Saroglitazar is a PPAR alpha and gamma agonist, and it has some advantage. So Saroglitazar was the world's first approved dual PPAR alpha and gamma, and has passed a long journey of almost 20 years now. And this is a unique molecule which has been made in India. It was the first NCE and the world's first glitazar approved by the controlling authorities in India, DCGI, for the treatment of diabetic dyslipidemia. It has a dual action, a PPAR alpha and gamma agonist. It has passed the phase 3 clinical trials and has shown a significant improvement in triglyceride, non-HDL cholesterol, significant improvement in glycemic parameters, no weight gain, no edema, no abnormalities in liver or kidney function tests, no myalgias, no myopathies, some amount of gastritis, dyspepsia, pyrexia, and asthenia, but these are very, very insignificant side effects and very infrequently seen. So what I tried to do, I tried to combine a dose of Saroglitazar along with Rosuvastatin in 10 milligram dose, and it was compared with 20 milligram of Rosuvastatin monotherapy in patients of type 2 patients of type 2 diabetes with dyslipidemia. So this was a retrospective observational analysis, and data was basically collected from the patient's case notes, medications and treatment charts of prescriptions, and laboratory communications with patients. 96 patients were initially selected, 6 patients were excluded as they denied to give informed consent, 15 patients were found inconsistent in compliance during analysis, and 75 patients were finally selected for analysis. Patients either received Saroglitazar 4 milligram once daily or Rosuvastatin 10 milligram and Rosuvastatin 10 milligram in combination, or they received Rosuvastatin 20 milligram, and they were on maintained metformin dose of almost 1 gram per day during the study period. 33 patients were on Saroglitazar 4 milligram once daily plus Rosuvastatin 10 milligram OD, and 42 patients were on 20 milligram of Rosuvastatin. The primary endpoints were change from baseline of HbA1c, low density lipoprotein cholesterol after 24 weeks. Secondary endpoints were FBG, PBG, and number of patients achieving HbA1c more than 7% and the non-HDL-C cholesterol. Patients before selections confirmed to be on stable medications for at least 3 months. Self-monitoring of blood glucose was educated to everyone, and they did their own SMBG with their own blood glucose with their own blood glucometers. This was the baseline demographic. Almost this was a population which was around 60 years to 58 years. BMI was almost around 25. Gender 21 versus 21 of these were males. Primarily, this was a male-oriented. Females were less recruited. Duration of diabetes was 4.8 to 5.2. Fasting was average 156 in the Rosua combination arm as compared to monotherapy of 151. PPG was 249 as compared to 244. HbA1c was 8 as compared to 7.9 in the monotherapy arm. TG was 253 in the combination arm as compared to 257 in the rosuvastatin monotherapy arm. Total cholesterol was 197 and in the combination arm as compared to the 185 in the monotherapy arm. LDL-C cholesterol was 134 in the combination arm as compared to 130 in the monotherapy arm. HDL-C was 36 versus 35 in the monotherapy arm. So this was the baseline characteristic, and these were the results which I'm going to tell you in pictorial format. So change in glycemic levels. A combination arm showed after 24 weeks a decrease in the fasting sugar from 156 to 121, while the monotherapy arm showed a decrease in 151 to 134. A postprandial showed a decrease of combination arm from 249 to 181 as compared to 244 versus 198. So saroglitazar with rosuvastatin group achieved a significant reduction in the glycemic parameters, both fasting and postprandial, as compared to the monotherapy arm. HbA1c reduction was 0.88 in the combination arm as compared to monotherapy arm. Change in non-HDLC, LDLC, and TG were also significant in the combination arm as compared to the monotherapy arm. Percentage of patients who achieved the target was 38% in the combination arm as compared to rosuvastatin arm. As I told you that these patients were put only on metformin 1 gram, and the risk of hypoglycemia was almost at par in both the arms. So to conclude, diabetes dyslipidemia has some unique features and may require specific considerations. Saroglitazan and rosuvastatin combination therapy is effective in reducing the non-HDL-C and the LDL-C cholesterol along with the blood glucose levels in type 2 diabetic patients with dyslipidemia. Overall, saroglitazar has been found to be well tolerated and there has been no serious adverse events reported. Saroglitazar is a potential therapeutic option in type 2 diabetic patients with high triglyceride levels not controlled by statins for a comprehensive control of lipid and glycemic parameters with acceptable safety profile. Thank you very much, and I would like to answer any queries on this presentation. Thank you very much.